Right. So now we're going to talk a little bit again about the specific kinds of dementias that I underlined before in terms of what kind of dementia is and what are some of the symptoms specifically of that one. So vascular dementia can present itself as stroke. It can be the result of a single stroke in some patients, and that would happen if it's in a very strategic place in the brain where a single stroke can make a complete and total difference to the way that a person functions from one day to the other. That's a fairly rare kind of situation. It's more often the case that the relationship is to multiple strokes or TIAs, which are actually not full strokes. They're symptoms of stroke that last for a period of less than 24 hours and then are gone again. Nevertheless, even though there is recovery from that 24-hour period, there is no doubt that a person who is prone to these events will perhaps have some accumulation of damage to their brain over time. And so that's not an uncommon situation, is to see someone who's had a number of TIAs or a number of small strokes, and it's the combination or the accumulation of those insults that leads to the dementia down the road. The risk factors for vascular diseases, so these risk factors are the same for heart disease as they are for dementia, but they include blood pressure. So somebody who's running a high blood pressure is putting themselves at risk, and that's one of the things that should really be addressed at the level of the primary physician. And it's up to the individual, obviously, to go to their doctor and keep a check on their blood pressure to make sure that it's in the right range. This narrowing of the arteries, this is really related to cholesterol, and so again, it's important to see your family doctor and have that kind of blood profile done to look at what is the ratio of the different kinds of cholesterol in your bloodstream, and to try to bring that into the recommended levels. Because
if somebody goes for blood work, will they get tested for all?
It depends on what your physician orders, right?
Okay.
But a lipid profile is usually done after a period of fasting, and usually your doctor would signal to you that you have to fast for 24 hours and then go get this blood work done,
sure.
And they'll do a reading on your cholesterol from that. Okay? So it's the cholesterol that is implicated in terms of these plaques that build up on the arteries and narrow the arteries. These narrowed arteries, therefore, make it more difficult for the blood to circulate through them. And then if you also have for instance, some problem in your heart valve where there's a blood clot that forms there, or a blood clot may form on the artery itself because there may be a breakage on the surface of it, a blood clot can form there. And once that blood clot dislodges from the artery and travels into the smaller branches of the arterial tree, it's just like a tree or a root system.
Right.
Once it travels into those narrowest arteries, at some point it will get blocked, and it will therefore cut off oxygen to the region of the brain that's normally supplied by that particular blood vessel. And that's a stroke, right? So that's how the cholesterol plaque relates to that. The other risk factors for coronary artery disease and also for dementia also include diabetes, also include family history, and also include smoking. So smoking is a pretty good one to think about because it's easily corrected. Well, maybe not so easily, but it's potentially correctable if you can find a way to deal with it. Okay, so the next one is frontotemporal dementia. So frontotemporal dementia, again, it's significantly different from the presentation of an Alzheimer disease pathology. And often in the early stages of frontotemporal dementia, it's not so much memory loss that is observed, although you will see memory loss as the condition progresses. But what tends to occur first is that there is a change in personality. And often that change is such that the person is doing things that are out of character. And they may include things like using language that the person wouldn't normally use, saying things they normally wouldn't say, being disinhibited about the way they might behave, not being so shy or so careful about their personal appearance. Those kinds of changes are the most frequent early changes. And also impulsivity, acting before you think kinds of situations. There's often a loss of insight early on, unlike the Alzheimer's situation where loss of insight comes a little later. This occurs right up front. So the person is manifesting these changes in behavior and personality, but they don't realize that that's actually happening to them. So that's called the loss of insight. And then, that will affect the way that the person makes decisions and the way that they act around their family and other social connections. There's another kind of frontotemporal dementia. So what I've described is called the behavioral variant of frontotemporal dementia. There's also a language variant of frontotemporal dementia, which is called primary progressive aphasia. And this is a situation where the person actually starts to lose words and starts to lose the ability to express themselves, almost to the point where after several years it's difficult to actually understand what the person is actually saying. It just struck me when, in terms of your question earlier, that sometimes those jerking movements that occur are actually the result of some treatments that the person may be taking, because often people are prescribed medications that cause different kinds of neuromotor abnormalities. And so those jerking movements can actually be the result of treatment with medications for the behavioral problems that the person is manifesting, and not necessarily a primary symptom of the disease itself.
Does this go away when the medication is taken away?
It may or it may not. Those kinds of symptoms fall into two clusters. There's an immediate side effect from those kinds of drugs, which would go away. If you get the drug out of the person's system, those tend to dissipate quickly. But if it's been in the person's system a long time, there are symptoms that are called tardive symptoms, and those are generally long-lasting. So it's not as easy as just taking medication away, and it resolves itself.
Is there any way of knowing which drugs might cause this?
These would be the antipsychotic drugs. They are the ones who would be most at fault. So they would include, I can list off a few for you if you like. Haldol was a very old drug that was used in that context, but there's also the more common ones that are prescribed these days include drugs like risperidol, olanzapine, and quetiapine. Quetiapine can be a partner problem in that situation. Okay. We can move on. Okay, so Lewy body. This is a very interesting condition as well. The interesting thing about this is that it's sort of like the first cousin of Parkinson's disease. With Parkinson's, the difference between the two things is that with Parkinson's disease, generally speaking, the symptoms are motor. So the person has trouble with their balance, they have trouble lifting their feet, they shuffle when they walk, they have a tremor. These are the recognizable sort of symptoms of Parkinson's disease. And with Parkinson's disease, in the long term, say 10 or 15 years into the diagnosis, a lot of people do have cognitive problems as well. They develop a Parkinson's-related dementia. Lewy body dementia is a bit different in that the dementia comes first. So the first symptoms are the symptoms of memory loss and related problems, and it's only maybe a year or two into those symptoms that you start to see maybe a little bit of tremor, a little bit of difficulty with balance. Those issues with Lewy body dementia also tend not to have the same course as Parkinson's, in that the motor symptoms don't tend to get that bad, over time out. Whereas in Parkinson's disease, 10, 15 years into the illness, most people are pretty affected by it. In Lewy body, it's more the cognitive part of the brain that's been affected. The hallmark of it, in terms of the clinical diagnosis, is this marked fluctuation in symptoms. That means that, a person may be very lucid and with it for 4 or 5 hours now, may be very confused for 4 or 5 hours later in the day, maybe back to being very lucid again 4 or 5 hours after that. So there's this fluctuating sort of course in the level of confusion or lucidity that the person experiences. And then there are the motor part, the tremor that may be there, and then there's visual hallucinations. And these do occur in Parkinson's disease as well, but again, late in the illness, but they tend to occur very early on in Lewy body dementia. So you can see how soft some of these things are and how they overlap with each other, and the necessity to really look into detail as to when a particular symptom started and what other symptoms might have been associated with that in terms of making the best diagnosis. And mixed dementia, I've already talked about a fair bit. So the more we understand about vascular diseases, the more we understand this link between vascular and Alzheimer's. And then finally, we have Alzheimer's disease. So this is a neurodegenerative disease, which means that there is destruction of neurons, brain cells, and these are not replaced. So over time, there's an accumulated amount of damage that comes from that. This is not by any means a normal part of aging. It's definitely a discrete pathology that needs to be understood in that way. And of course, it's the commonest of the dementias, accounting for 65% of cases. Some risk factors for Alzheimer's disease. Number one is age. We know before the age of 65, with the very rare exceptions of genetically mediated Alzheimer's disease, before the age of 65, this is quite a rare condition. After the age of 65, the rates grow and grow from 5 to 10% at 65 to 33% at 85. So age is the single biggest risk factor. There is risk factors associated with family history as well. So there have been 3 genes that have been linked to Alzheimer's disease, and individuals who have that, these are genetic mutations associated with Alzheimer's disease. Individuals who have these genes have a known mutation, which translates into excessive production of a protein called amyloid. And it is the deposition of this amyloid, which we think is the thing that starts the whole cascade into dementia. So this is an abnormal protein that is made because there's been a genetic mutation in one of these 3 genes. Now what I'm talking about here is a very rare entity. There are only a few dozen families in the world known to have these particular mutations. This is not what we see just about every day in the clinic. This is a different situation. And in these individuals, the onset of the illness is often early. And certainly I've seen some patients in their 40s who had this condition. The other thing to remember about it is that this is an autosomal dominant inheritance, which means that these are very clear when you look at the family history of the individuals who have this mutation. It's very clear the transmission the way that it's transmitting through the generations. And it's that 50-50. If you have a parent with it, you have a 50% chance of inheriting that gene. But keep in mind that these are early onset Alzheimer's disease, and most early onset Alzheimer's disease is not this. Most early onset Alzheimer's disease is still the sporadic form. But what's interesting about knowing this genetics is the way in which that has allowed us to understand the pathology of it in terms of the deposition of this abnormal protein in the brain. There is an increased risk if you have a family member with Alzheimer's disease of the common variety. There is still a bit of an increased risk, from that as well. And the increase in the risk is probably 3 or 4 times that of the general population from having a first-degree relative with it. I don't know if that's clear. I hope that's clear. It's very complicated, area, and I'm just trying to kind of highlight a few things that I can say with certainty about it. Okay, so these are some other possible risk factors. So we know diabetes for 2 reasons, because diabetes increases the risk for vascular disease, but also because we think that there may be some relationship to insulin resistance in the brain. So normally insulin is thought of as being in the general circulation, affecting glucose metabolism. But we also think now that there are receptors in the brain for insulin as well, and that we think that the insulin resistance is tied to the pathology for Alzheimer's disease and therefore to diabetes as well. Down syndrome, this is on chromosome 21, and this is the chromosome on which those other rare kinds of genetic Alzheimer's also exist. So the link between those is pretty clear. Head injuries are definitely related to dementia. And the lower levels of intellectual, development and stimulation, I've mentioned that already.
Do you think these pathologies existed for thousands and thousands of years?
I think that's the case.
Like, there's a lot of stuff locked in the DNA, a lot of old diseases, and so this isn't because of the way modern society is. It's not something came with the industrial age or change of habits and all this stuff. It was always there.
I think it was always there. I think we see it more now because people live longer, because we have the means by which to make a better approach to diagnosing these problems and a better means by which to study them. I don't, there may be some cultural and social factors like diet and things like that influence it, but I think it's really always been there. Keep in mind that in the Middle Ages, the average lifespan was 32 years.
Unless you were a royal.
Yeah.
You might live to be
And
100.
a lot of them didn't do very well in old age.
Huh.
All right.
I don't see it.
Yeah.